there's a little bit of the sense of the field trying to build the plane while they're flying it in terms of what data exchange looks like, what tools are being used, how it's being stored.
We're excited to brainstorm and share new ways to integrate those codes and see if we could make sure to capture all the work that clinicians are doing to address social needs, but also healthcare delivery systems as well as health plans.
Hello and welcome to Healthcare Strategies. My name is Hannah Nelson, Assistant Editor of Health IT and EHR. Research shows that social determinants of health can drive as much as 80% of health outcomes. However, standardized documentation of social needs is lacking, limiting efforts to improve population health. Joining us today is Rachel Harrington, Assistant Vice President of Health Equity Sciences at NCQA, and Adriana Nava, Applied Research Scientist, Health Equity Sciences at NCQA, to discuss a new study published in Health Affairs Scholar that explores early lessons of integrating social determinants of health data into practice. Rachel and Adriana, thank you for joining us.
Nice to be here. Thank you.
Thank you.
Now, kind of just diving right into it, what motivated the study that you guys have recently published?
So for those who are not aware, in HEDIS, which is our quality improvement tool that health plans use to measure performance, we recently developed our social needs screening and intervention measure. And in that measure, we assess for unmet food, housing, and transportation, and whether or not an intervention was given to someone who screened positive within a 30-day time period. And in doing this measure and having it included in HEDIS, we noticed that there were other measures in the field as well that had additional domains that our measure at the time didn't take into account. For example, the domain of utility and security was one of those. And then there's been a lot of talk about the importance of social connection. And a part of social connection is loneliness, social isolation, inadequate social support, and looking at what that would look like as a measure. What we've done at NCQA is do some pilot testing, which you can read about in our study, where we were looking at the feasibility of collecting data on the new domains of utility and security, as well as social connection within our current measure space for social determinants of health. One of the major findings we found was the lack of standardization in the way that information was collected. And the first piece of that is in our first indicator, looking at social needs screening. And we've noticed that there's a variety of ways that individuals or plans or providers have been collecting that information. So NCQA recommends, aligned with Gravity Project terminology, is to use evidence-based screening tools. But we did notice that even though this is recommended, there are some delivery systems that are creating their own screening tools. We've also noticed that some states are also developing their own tools or using other tools that are not within our list of validated tools or have terminology associated for them to be able to collect that information. So there is a great opportunity for us in the larger SDOH field to begin to hone down on what tools that we want to include in measurement, but also making sure that they have the terminology to capture that information and be able to cross across like an EHR as well as case management files and making sure that it's capable of being a digital information that's being transferred.
Yeah. And what I think people don't always realize about measure development, measurement is seen as this very quantitative science, but half of the work that goes into it is the qualitative work of trying to understand why things are happening and how things are happening and how they're not happening. And this paper, I think, really highlights that qualitative background that shapes so much of what we do and what the measure is trying to achieve.
Great. So based on that, what did you find in the study? Passing it off to you, Adriana, what were the study's main findings?
So one of the things that we thought was really interesting, looking at a little bit broader than just quality measurement and what kind of data elements are there, but the role that policy plays in helping to build that standardization process. So really relying on policy, whether it's state level or national policy, to help the infrastructure to be built. So we know that as we continue on this digital journey, making sure that we are in sync with what data elements are currently available, but what type of infrastructure is needed in the future to make sure that data transfer is seamless.
With all these different kind of tools being used and standards, based on your findings, what are the implications for social determinants of health data collection from here?
There's a little bit, I don't know, Adriana, if you'd agree, there's a little bit of the sense of the field trying to build the plane while they're flying it, in terms of what data exchange looks like, what tools are being used, how it's being stored. And to the point that you just made, there are, I don't know how to continue the analogy here, there are blueprints out there. The Gravity Project is a blueprint for how to do this. And so trying to figure out like how people are navigating this in such a dynamic environment was one of the things that stood out to me about this work.
Were there any findings from the study that kind of stood out to you or something that was particularly surprising or unexpected?
I think what was surprising was the high variability in the amount of plans that were able to map to current codes that we were requesting in our measure versus those who couldn't. So there's definitely an opportunity to still learn what the barriers are in addition to the data challenges, but seeing if maybe there's challenges with screening members. Some may be declining that screening, which our measure at this point doesn't capture. So there's a lot of opportunity to see what other barriers or challenges are there that are prohibiting health plans in particular from collecting this necessary data. But it was good to see that there are health plans that have been able to map to LOINC codes or pull LOINC codes from EHRs. That was really great to see as well.
For me, I'm going to look on the positive side here. It was exciting to see the engagement from plans across all product lines. You typically, Medicaid plans, Medicare plans, there are policy levers in place that are helping those plans focus on this. But there were commercial plans who were part of this study too, and were able to really engage and discuss their work here. And when you look at the findings, and there's a table in paper that summarizes the different plans and their ability to capture screenings and interventions and how they're coding it, the screenings are challenging, but most, if not all, close to all of the plans did have some sort of systematic capture for interventions. And while there are challenges to focus on here, there are also elements that you're like, oh, there's progress, because I don't think if you had done this 4 years ago or 5 years ago, you would have seen this level of engagement and broad engagement across plan types.
Great. That's great. I love to hear looking on the bright side. There has been progress in this kind of field and really good to focus on that at the end of the day. Now, not to bring us back to the challenges, but in terms of the barriers that exist, the multiple systems and different standards and formatting challenges, how do these challenges impact health plans' ability to collect and utilize this kind of social determinants of health data effectively?
Yeah, it was really interesting to hear about health plans having to navigate among different data systems and knowing where to find specific codes, especially since these are newer codes that we're introducing to the field. So being able to navigate, like, where do I find the LOINC code, or where do I find the SNOMED or the CPT? And, oh, I have these Z codes that you're not asking for, but, they're being documented.
An entire alphabet of code.
Yeah. So what do we do with those? Those are important as well. It was just really interesting to hear it was honestly positivity. Like, health plans that were part of the study were excited to be doing and be a part of this work. We're hopeful that this will help shine a light on the work that health plans are doing to try to collect this information on their members.
That's wonderful. Yeah, to know that there's that general excitement and kind of commitment to wanting to collect this data and knowing how important it is definitely something to highlight. So that's great.
It's interesting too, because I think a lot of the work done in this space so far has been done on the sort of clinician provider health system side. And this is, as far as I am aware, one of the first looks at the health plan side of things. And so it lets you sort of put the picture together. And there's almost an empathy in this, because if you imagine the health plans are dealing with all of these different approaches, and then they're trying to work with all of their contracted providers and systems who themselves are contracted with multiple plans, you can see where this all gets so confusing and challenging in practice.
Totally. Yeah, that's so true. So, I guess based on the research that you guys have done, what are the next steps for health plans and policymakers in terms of making social determinants of health data collection more feasible and more usable in practice?
So one of the things that we've been working on at NCQA is looking at new codes or terminology that's available to capture SDOH. screening, but also potentially some interventions. So that's looking specifically from feedback that we've gotten from our field testing sites of the Z codes. How did we introduce that into our measure, for example? We know with the recent physician fee schedule of 2024, there were additional HCPCS or G codes that were introduced there. So we're excited to brainstorm and share new ways going forward in order for us to be able to integrate those codes and see if we could make sure to capture all the work that clinicians are doing to address social needs, but also the healthcare delivery systems as well as health plans.
Yeah, now jumping off of that, what kind of future research or pilot projects would either of you and both of you like to see in this space?
I think one of the things that stands out for me is the environment, the sort of networked environment here, all of the different contributors. We've talked about the clinicians, the systems, the plans, which was the focus of this study. You also have the community-based organizations, many of whom are being tasked either to do the screenings or to provide the interventions that these sorts of measures and all of these codes we're talking about are documenting. And I think for us, really leaning in on trying to understand a kind of a map of all of those contributors and how the barriers and facilitators that Adriana and the team found in this study maybe compare between them. Ideally, you find a common barrier that you can solve that makes everybody's life easier. But chances are there are likely unique elements there. And so, how do we make sure that when we're solving the problems for the health plan, we're not making more problems for the community partner, right? So, I think that is something that we'll definitely be hoping to look into more as we go forward with this work.
Yeah, and I'll just like to add on. So, as we continue to standardize the way we collect this data, we're hopeful that when we look at social needs, we'll be able to tie it to specific health outcomes and be able to take these measures even forward and see how they're contributing to maternal health or other areas that are of interest at NCQA. That's why it's so important right now with this research study to be able to work on getting and collecting this information in a standardized way, but also making sure that information is digital and being able to be transmitted across the healthcare system. But I wanted to highlight this as well. We noticed that health information exchanges are not used as much for the transfer of information. So there's a great opportunity there to work with states and public health infrastructure to be able to see how we can move the needle forward in collecting this essential information across populations.
Definitely. Yeah, thank you so much for adding that, Adriana. That's very important and definitely something that we need to keep in mind. So, looking towards the future again, how soon do you think health plans will feasibly be able to implement these measures to really improve population health?
Mixed bag.
Yeah.
It's so one of the things I think we found in this study is many of them are already implementing this work. It's just the documentation that's lagging behind. But there's a reason we measure and we ask for the documentation, which is without that documentation, that transparency, you don't know if the interventions, the screening are making it to all the populations who need it. And to Adriana's point, you don't know if they're working. Are they impacting outcomes? It's like core quality measurement 101. You can't act on what you can't see. It's really taking the work that's already being done, getting it streamlined in a way that can be documented so that it can be evaluated and see where it goes from there. But plans are already doing it. Medicare already has measures that are required at various levels of care for work like this. You're seeing CMMI models that have been doing this work, the Accountable Health Communities model. Recently had some evaluations come out that showed really positive impacts. So it's, I think, just helping different parts of the field catch up with each other. And hopefully, I don't know, Adrian, your sense, hopefully we're not too far away from
Yeah, I hope not. Yeah, like you said, the work is being done. So it's exciting, even when we're looking for field testing partners. A lot of enthusiasm and participating and sharing the great work that they've been able to see, and also trying to be partners in identifying solutions to some of the challenges that we mentioned. That's really exciting to be a part of.
And frankly, it makes business sense. A lot of these organizations are doing this work or started doing this work before there was ever any measurement or requirement to do it. And it, again, it goes back to quality 101. If you want to get the most out of your interventions, you need to make sure that you're addressing all of the root causes, the unmet needs. If you invest $1 million in diabetes and you're not paying attention to food, housing, or transportation, you're not going to get $1 million of outcomes.
Mhm.
So I think there's an internal motivation here too.
That definitely makes sense. So, wow, thank you guys so much for coming on the podcast and joining me today. This has been a great discussion.
Yeah.
No, thank you. It was a pleasure.
Thank you.
And to all of our listeners, thanks for joining us. If you're interested in learning more about this topic, check out our site dedicated to health IT at techtarget.com/search health IT. If you have thoughts on this topic, or if you have any healthcare related stories that you'd like us to consider for coverage, you can reach out to me at hnelson@techtarget.com. That's HNELSON@techtarget.com. Follow us on Spotify to get more of these conversations, and let us know what you think by rating and reviewing the show. See you next time.
Music by Kyle Murphy and production by me, Kelsey Waddell.
This is a Tech Target production.